Good afternoon, everyone, and welcome to LGBTIQ plus Health Australia's first policy and research webinar of 2025. It's nice to see so many people joining. We will just give a few more minutes for a few more people to join, and we'll get started soon. Actually, we might begin because we have large attendance, so we've got a lot to cover this afternoon. So again, good afternoon, everyone, and thank you for joining us for our policy and research webinar, which is titled "Where Are We Now? Research on Gender Dysphoria and Priorities for Australia." My name is Ian Dunn, and I'm the policy and research lead at LGBTIQ plus Health Australia, and I use he/him pronouns. LHA acknowledges the traditional owners of country throughout Australia, their diversities, histories, and knowledge, and their continuing connections to land and community. We pay our respects to all First Nations people, to elders of past, present, and future generations. I'm joining today from the land of the Gadigal people of the Aurora Nation, and I pay my respects to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people joining us today. I recognise that sovereignty was never ceded and that this always was and always will be Aboriginal land. And as we gather for this webinar, I invite everyone to take a moment to reflect on the lands you are on and the deep histories that continue to shape them. Please feel free to use the chat function to share where you are today. Before we begin, I'd like to mention a few housekeeping items. Our webinar today is being recorded and will be made available on the LHA website. If you miss any information, you will be able to find it there and go back and listen. After our presentation, there'll be an opportunity to ask questions. I invite you to use the Q&A function, which for most Zoom users is located down at the bottom of your screen. Please feel free to ask questions at any time, and time permitting, we will come back to them at the end of the presentation. So our guest today is Professor Peter Bragg from Monash University, who led a comprehensive review of the evidence on medical and psychosocial interventions for young people with gender dysphoria. And Peter will provide an overview of the results of that review in a presentation that Peter titled, "Where Are We Now? Research on Gender Dysphoria and Priorities for Australia." Now, when Peter and I planned this webinar, it was back in November, and we couldn't have predicted how timely this discussion would be. Right now, gender-affirming care for young people is at the centre of national debate, making today's focus on research and evidence more important than ever. It's important to acknowledge that the past week has been incredibly challenging for many. When healthcare decisions become political, they can create uncertainty, fear, and distress for the people most affected. That's why today, again, it's critical that we focus on what the research actually tells us. So I'm sure people are aware, last Tuesday, the Queensland government announced a pause on new gender-affirming medical treatments for people under 18 in the public health system, citing concerns about clinical practices and commissioning an independent review while allowing existing patients to continue treatment. And then last Friday, the Honourable Mark Butler, MP, Minister for Health and Aged Care, announced that he had asked the National Health and Medical Research Council, the NHMRC, to undertake a comprehensive review of the Australian standards of care and treatment guidelines for trans and gender diverse children and adolescents in Australia, and to develop new national guidelines. And I'd just like to be clear that, so this session is about the research. While recent political announcements have understandably sparked debate, today's focus is on the evidence that Peter and his team reviewed, so what we know and what gaps remain. However, for anyone who would like information about either of those announcements and what they mean, I will be dropping some links into the chat as the presentation goes on, where you'll be able to find more information. And we are in the process of scheduling a webinar perhaps a few weeks from now, where we will cover those the current situation in much more detail and answer any questions people may have. I'll also drop my email address into the chat, and please, if there's anything that you would like to know more of about the current situation, then reach out and I will get back to you. And if you'd like to stay informed as things develop, I encourage you to check out the websites of Transcend Australia and AusPath, which will continue updating their resources. So we also want to acknowledge that these are difficult times for trans and gender diverse people and their families, not just because of what's happening here in Australia, but because of the broader international climate. The scrutiny, the debates over the access to healthcare, it's a lot. So if today's discussion feels heavy, please look after yourself. And if you need support, Q Life is available, and I will be giving those details at the end. So if anything in today's webinar raises concern for you, support is available. Q Life provides Australia-wide support, and the services are free and include both telephone and web chat support. And finally, just a note on chat etiquette. Please use the Q&A function for questions. And while discussion in the chat is welcome, let's please ensure that it remains thoughtful, respectful, and supportive for everyone participating. So now let's meet our speaker, Professor Peter Bragg, who's one of Australia's leading experts in evidence reviews. Professor Bragg has been recognised as one of Australia's top 250 researchers in health policy and medical law. He's the director of Monash Sustainable Development Institute's Evidence Review Service. He's published over 250 papers and reports, and his latest book, Inspiring Change: How to Influence Behaviour for a Better World, which was published in 2024, includes a chapter on evidence review methods. And today he's here to walk us through what the research tells us about gender-affirming care for young people. So please join me in welcoming Professor Peter Bragg. Thank you.
Thanks very much, Ian, and thanks for the invitation. I'd like to acknowledge the traditional owners of the land that I'm joining from down here in the land of the Kulin Nation, and their elders past, present and emerging. And I'd like to welcome everyone here. As Ian mentioned, it's been a really interesting week, and I hope to be able to give some context to the work that we did through this presentation. And as Ian said, we'll take some questions afterwards. So I'm going to dive straight in. I'm hoping that you are seeing the presentation slides now, but I'm sure someone will let me know if that's not the case. So I think the first thing that I need to point out is what Ian referred to just before, that and I've put a red marker around these dates because I think they do give some context to the talk that we're doing today. So the first thing to say is that this review was published almost exactly a year ago on February the 1st, 2024. And then I've just grabbed a few screenshots from a few of the news stories that have come out in the last week. And I think Ian's covered that pretty well. I did look at the NHMRC website yesterday, and in red, I've just put that the new guidelines are going to take a few years, but they're hoping to publish some interim advice in the middle of next year. So that's just the publicly available information from the NHMRC website. I don't have any direct connection to that information, but I'm sharing it with you today. I'd like to pay credit to the SATS Institute for the opportunity of undertaking this work, and to the team that worked really hard, as you'll see when I go through the results, on reading cover to cover over 80 studies and really drilling down into what the research was that they did, what they found, and the quality of the research. The team included a specialist librarian, Kong Lem from my team, and two academics from the University of Melbourne, Meredith Temple-Smith and Lena Sankey, who led the previous review, which this review was updating, and I'll expand on that shortly. As Ian said, and I think it's really important to point this out, we are an evidence review service that does evidence reviews on lots and lots of different topics. This particular review is a desktop review, but we do a bit of work in talking to experts to understand the local context. We spend a lot of time working with governments, philanthropic organisations and other civil society organisations to understand the questions that they're asking and connect research to those questions. And we do a bit of teaching and training in review methods. So it's a kind of a, and I'll just show you this slide just to indicate the breadth of the review work that we do. And in showing you this slide, I'm also hoping to convey that I'm not a clinician or an expert in gender dysphoria treatment per se. I'm essentially a professional systematic reviewer. So I know lots about how to find research and make sense of it. But my expertise is really around the methods of reviews, and I apply those methods across a number of topic areas. I also, I'll get all these disclaimers and background information out of the way as soon as possible, but I think it's also important to position the work that we did. So we were tasked with doing a review of the desktop evidence, not a clinical practice guideline, which is what NHMRC is planning to do. So our report, if you have accessed it, and I'm sure Ian will send a link to the report, you'll see that it contains lots of tables with lots of summaries of lots of research studies, but it doesn't make statements or take positions on what that means for either policy or practice. That's not part of the work that we do. Obviously, people, we hope, are going to use this evidence review as a foundation for those discussions and activities. So that's another thing just to make really clear. In terms of the actual questions we were asked to address with our desktop research, they were essentially in two broad categories, covering sort of three areas. So what evidence can we find about the effectiveness of medical interventions and psychosocial interventions for treating transgender and gender diverse young people with gender dysphoria? And I'll go through that definition shortly, but we were focusing on people under 18 years old. At the same time, and if you look at the evidence tables, you'll see that we've also catalogued the risks or potential harms from those interventions, and we've looked at whether those risks or harms or effectiveness data vary across the studies, and that's the results that I'm going to present today. I will spend a few minutes going through the methods, and I promise I'll then focus in on the results, but I think the parameters of the review do deserve a little bit of attention so that we can be really clear what we did. The first thing we did was that we focused this review on Australia and countries that, with our collaborators at SACS and the New South Wales Ministry of Health, were deemed to have comparable health services, and none of those countries will be surprising. It's important to say what we didn't include, and certainly we were looking at what we would call clinical research, where people have recruited patients to evaluate treatments, or reviews where people have reviewed clinical research. So we didn't include opinion papers or commentaries that are not reporting the results of actual research, and we didn't include very small studies. One of the things that's really important to point out is that we were looking at treatments for the condition which is classified as gender dysphoria, and that's defined as clinically significant distress arising from the incongruence between birth assigned sex and gender identity. So that's the population that was of interest in this review. We accepted studies of people up to the age of 25, as long as half of them were under 17 or equal to 17. And we also looked at studies that had followed people up over time. Again, in the right-hand column, it's important to point out that we excluded studies of views of people about gender dysphoria treatment. And that's not because we don't think they're important, it's just because the focus of this review was, what are the treatments and what's their effectiveness? We know that those conversations are going on, and we know that people have views in this, as well as many other areas of medicine. And this is on the left, the column of the interventions that we looked at. And because we were focusing on children, we only looked at chest surgery. We did not look at genital surgery. But I will go through those areas in detail shortly. We excluded conversion therapy, which is being widely discredited and in fact banned in Australia and many of the countries that I listed earlier. And we also excluded papers looking at ethical issues and legal issues. Again, we know that those issues are important, but they weren't within the scope of the review that we did. This is a very boring slide, but for those of you who know about reviews, you will see that we followed a best review practice. We had 2 people independently screen the literature. We assessed the quality of studies using accepted evidence grading and critical appraisal techniques. And if you have read the report, which I think is nearly 200 pages, you'll see that we've detailed really all of the key information for all of the included studies. So now I'm going to go to the results, and I'll start with, I guess, the headlines that many of you will be interested in at a summary level, and I'll present a slide on each of these. But in summary, we found that puberty suppression can delay the physical changes of puberty, is generally safe, and was reported as being reversible. We found that hormone therapy can help people to develop the traits that match their gender identity and can cause improvements to mental health and well-being, with serious side effects being rare. Fertility preservation is a really interesting area, and obviously there is a lot of research about fertility preservation within and outside of the context of gender dysphoria. And what the gender dysphoria specific research confirms, like research in other areas, is that essentially freezing sperm and eggs are effective techniques. There are some concerns, there are some reported differences in sperm quality in people who have had puberty suppression, and there are some issues around treatment procedures, which I'll unpack when we get to that slide. Psychological support, a little bit like preservation of fertility, is an intervention that is applied in many, many domains and therefore has a strong evidence base globally. And certainly the studies we looked at that were specific to gender dysphoria indicated that psychological support is safe, effective, and well received. That's an unsurprising finding given the levels of research into psychological therapies. And we did find that chest surgery had some important psychosocial benefits and benefits in terms of reducing feelings of distress. I want to talk about the studies that we found. Oops, I've skipped a slide. So this is a summary in the middle column of the years that were covered by the previous review, which covered the years 2000 to 2020. And on the right-hand column is what our review added to that evidence base. And if you look at the numbers in the bottom 3 rows, in the context of the years covered by the review, you can see that we had nearly double the amount of studies from the previous review, but we were only adding another 5 years to the previous review's scope, which was 20 years. So what that tells us is there's obviously a big uptick in the volume of studies that have been published. And so you can see on the bottom right that we reviewed 82 studies between 2019 and 2023. But it's very important to point out that over half of those studies were relatively low on the NHMRC hierarchy of evidence. And I will unpack this a little bit because it does give some context to the following slides. Research is positioned on a hierarchy which broadly reflects the strength of the study designs. And we know that systematic reviews, because they bring together studies from lots of areas, are the most robust because they're controlling for studies that are outliers. So on one level, it's great that we found 16 systematic reviews in this review. However, most of those systematic reviews didn't contain randomized trials, and there are some important ethical reasons why that isn't the case. Sorry, I've lost the slide there. There are some important ethical reasons why that level of evidence doesn't exist. But in these middle rows of the studies that are possible, comparative studies with concurrent controls, there's a relatively small volume of evidence. Whereas the case series and cross-sectional studies, which don't have any form of control, represented the highest volume. And so we've got a situation where we've got a large number of studies, but we don't necessarily have a large number of very robust studies. So we have some evidence, but we don't have evidence of as great a strength as we would like. So I'm going to go through those individual findings. I'm just keeping my eye on the time to make sure that I'm not going for too long. We found 17 studies pertaining to puberty suppression. And as I mentioned in the summary, it is generally safe, effective, and reversible. There is some information about the effects of puberty suppression if you proceed to later stages in a gender transition journey. And they do have some implications. There's a small volume of evidence for positive impacts on gender dysphoria, and there is literature to show that puberty suppression reduces bone mineral density, but it should be monitored, but not dramatically. So people aren't getting fractures and serious side effects, but it's definitely something that most clinicians would keep an eye on. As I will say in every one of these slides, the strength of the evidence that led to those conclusions is relatively low because of that slide I showed you, that many of these studies, and in the case of puberty suppression, you can see that 9 of the 17 studies are at that case series cross-sectional level. With regards to gender-affirming hormone therapy, this was almost half of the 82 reviews, and essentially, as the previous review found, gender-affirming hormone therapy is effective for causing changes in body composition, which is unsurprising in some respects. And some of those effects are on body mass index, growth, bone maturation, and menstrual suppression. Interestingly, gender-affirming hormone therapy appears to offset the problems with bone density in puberty suppression. In fact, it appears to increase bone density. And there are a range of psychological benefits that I've listed there across a number of domains, but it's important to also point out there are some neutral and negative findings, but generally the findings are positive. Serious adverse outcomes are rare, and as I've said, and as I will say, the study designs remain generally of low in hierarchies of evidence. Gender-affirming surgery was really interesting. In terms of the studies that we found, we did see some high-quality comparative studies with positive findings specific to adolescents, and this is one area where you would expect comparative studies to be less feasible or less acceptable, but there are some, and you'll see if you access the report, you'll be able to see exactly what those studies are. Complication rates were reported as low, and the generally positive findings around psychosocial outcomes, gender dysphoria, and sexual function and quality of life, and some mixed findings in subgroups, transgender men, as well as on quality of life. Clearly, the irreversible nature of surgery or the difficulties involved in addressing a surgical procedure in the longer term are a key risk or potential harm. There's a whole body of literature around detransitioning regret rates that wasn't within the scope of the review, but it was reported as low in these studies. As I mentioned earlier, fertility preservation is an area that has an established evidence base in a number of domains. The interesting finding from my perspective was that the uptake is still pretty low, and there is low awareness. But study authors do note that most do not desire biological children. So there's a range of factors driving people's access to treatment, and cost is one of them as well. We know that cryopreservation or freezing is an effective procedure. There are some studies that report a lower quality semen in the context of puberty suppression, and there are some psychological issues around harvesting of both semen and oocytes that need to be considered. And there is some variation in things like hormone use in cohorts. So that is one limitation of those studies. Finally, and as I said, this is not an entirely surprising finding, but the psychosocial therapies had good evidence across suicidal ideation, psychological distress, depression, anxiety, and gender minority stress, and that interventions are acceptable and safe with no risks or harms reported. But in addition to there being not a large number of studies, there's a lot of variation in the psychological interventions. Some of them were online, they're delivered in different settings. They often have mixed populations with no subgroup analysis, and they're by definition a much more disparate range of therapies than the other ones that we've discussed today, that I've presented today. So it's important to note the research limitations, whilst also acknowledging that gender dysphoria research is challenging, and there are a range of ethical considerations around running trials that make it very difficult to do that. But the things that we observed across the literature were that the sample sizes were relatively small and usually came from single centres. There was some variation in the intervention characteristics, things like hormone doses, the level of description of dosing schedules, variation in the outcome, and in a number of studies, some of the other things that might affect bone density, like smoking, vitamin D levels, and lifestyle, were not really controlled for. One of the things that's a little bit challenging with adolescents is that it's not universally defined in research terms. Obviously, most people think of an adolescent as under 18, but a lot of these studies had mixed cohorts up to the age of 25 and older. And so we had to come up with some ways of dealing with that. As I said, we don't make recommendations for practice or policy, but from a research perspective, there were three really important messages. One is that we need to keep following up cohorts longitudinally, and that's been done now in some of the bigger centres for 10 or even 20 years to build understanding of the longer term outcomes. There are a number of areas of research such as spinal cord injury research or motor neurone disease research where the populations are relatively small, and the way that research tries to deal with that is to collaborate and have multi-centre studies, and that's a very strong recommendation. And whilst we know that randomised controlled studies are not possible, there are other controlled study designs, waitlist controls. Some of the studies out of the Melbourne clinic were comparing people on the waitlist around psychological therapies with people receiving therapy. So it's difficult, but it is possible. I just want to reiterate in closing a couple of things about what's next in this space. And I think I'm really encouraged by the fact that NHMRC is going to build a nationally consistent clinical guideline. We've compiled fairly comprehensive evidence review, and combined with the previous one, we've certainly got a comprehensive coverage of the studies in this space. The next steps are really to now engage with other stakeholder groups and make sense of what this might mean for policy and practice. And finally, I do want to point out, and we've done some more detailed comparisons, but a lot of people talk about the CAS review in the UK, which I'm sure most people in this audience have heard of. We just want to point out that the CAS review was, I mean, the only thing in common with one of the few things in common is the word review, but they were actually reviewing a gender service. And you can see on the title, they are reviewing gender identity services. We were reviewing gender dysphoria literature. So they're not really comparable. There is overlap in the research evidence that has been reviewed in the CAS review and in the study that we did. But really the terms of reference for the CAS review were really around making policy recommendations around service delivery. And as I said, it's great that the NHMRC is now going to embark on a process of convening groups to determine the best evidence-based policy and practice in this space. Thank you very much for taking the time to attend and to listen. I'm going to end the slideshow now, and I'm happy to take some questions.
Thank you very much, Peter. It's very interesting, and I do not see any questions in the Q&A other than Teddy, which I've answered. But there was a question that was put into the chat, so I might begin with that one. But if people could, if people have any questions, if they could enter them into the Q&A, that would be wonderful. So Andrew asked if there was a reason why, or if you could provide the reason why bottom surgery are excluded from the review.
Only because we were specifically asked to review gender dysphoria treatment in youth. And the context of this review, people would be aware there was some concerns about service delivery in Australia, and they pertained particularly to youth. And so they were just out of scope in terms of the direction that we were given from the New South Wales government and from the Sachs Institute. It was essentially not within the scope of this review. But we know that evidence exists in that space, and obviously for the clinical practice guideline, which I presume will cover all ages, that evidence will become within scope, you would think.
I'm also just curious about, so over the course, between the first review and the update, the number of studies that were being conducted and the number of citations and papers increased pretty dramatically. But yet you mentioned that the increased volume was compromised because the study designs were not great. Can you speak to that a bit? Because you would think that more studies being done, it would be refined, it would become.
Yeah, well, certainly. Yeah, I think it's important to make a distinction between the volume of evidence and the types of studies that were done. So I think in the in the table that I showed, essentially, I think the uptick in volume is a combination of a couple of factors. One is that some of the established gender dysphoria clinics and centres have got a lot more longitudinal data. So they're following cohorts on. And there are people who are obviously also publishing in this space. So if you look at any area of research, if you've ever read a bibliographic overview, most of the reviews say, oh, look what's happened in the last 5 years. There's a heap more research. So it's not inconsistent with increasing research effort and availability of research. But I think the point about them being single center studies is that just because you have a lot of studies, unless they're comparable directly, it doesn't necessarily transfer to a strong evidence base. And I think this is a bit of a conundrum. So all clinical practice is based upon the best available evidence. This is the best available evidence we have. So we now, as a community, the clinical community and the policy community, need to make decisions about that evidence. But in any area of medicine, it's not necessarily the volume of studies, but it's firstly what they did. And it's also the extent to which studies can be compared across each other. And in this case, what they did isn't consistent because there are so many variations and complexities. Gender dysphoria treatment is essentially a long treatment pathway where people have had bits of different therapies over the years. and it's being done in different parts of the world. So that's in a nutshell why that's the case. I can see some questions in the Q&A, which I'm happy to take in order.
Do you want me to read them out? Or...
Oh, I'm happy to read them out.
Okay.
So Kenton Miller's asked about what areas I hope to see covered in the NHMRC guidelines and how they might differ from the Melbourne RCH guidelines. Broadly, I haven't really thought about what my personal wish in terms of the scope is, but I think that the important thing about a national guideline, there's a couple of things about it. Firstly, it will ensure that there are a consistent set of guidelines across Australia, and that's not to disparage any of the existing guidelines, but it just means that more clinical services will be involved, more stakeholders from around the country, and that will create a more consistent picture, and that's always a good thing. The second thing is that the NHMRC process is very robust and well respected, so I think that it will become a document that will be very important because of the processes that are attached to that. I don't have a personal view on what areas should be covered, but I think obviously the areas that we covered, and I would presume that, as the previous questioner asked, I would presume that the scope would extend to adults and other therapies that are available to adults, but I actually don't know, and I'm not sure that the NHMRC have reached the point of determining the scope. Jacob has asked, do you have papers you could refer to regarding the different controlled trials that could be utilised? There are lots of papers that talk about those different study designs. Probably the easiest document to access would be the NHMRC hierarchy of evidence. If you just Google that, it's a fairly old document, but it essentially lays out those four or five categories that I presented. Also, if you do make it to the appendices and the index of our report, you'll see that we've defined and described all of those study designs. But to cut a long story short, there are ways that you can compare outcomes to a control group without compromising ethical considerations. And as I mentioned, one is historical control. There's a very interesting study from the US that used sibling control. So there are some strategies that you can use to generate those comparison groups. Vicky Sinnott has asked about the disparate nature of the studies in the psychological therapist section, and added that she's aware of pressures on the child and adolescent services and private providers. Yeah, so I mean, obviously mental health services are stretched everywhere. I think from a research perspective rather than a practice perspective, what we observed was that because these populations are pretty small, many of the studies were including but not limited to people with gender dysphoria. So one of the studies, I think, was an online support services for anyone experiencing anyone going through gender-related or sexuality issues. So what that means as a researcher is that it's hard to work out exactly what the effect on people with gender dysphoria is. And then there are a combination of obviously psychotherapeutic perspectives. So there's family therapy, there's one-on-one counselling, there's psychiatric support. So when you've only got a handful of studies and you consider the breadth of psychological therapies and the population is small and mixed with other populations, it becomes very difficult. Whereas something like gender-affirming hormone therapy, it's a drug, it has a particular formulation, it has a much more it's much easier to define as a therapy. So I think that's what the challenge was there.
And there's another question that Teddy has put in the chat. So Teddy asks, he says, thank you for a great presentation. And he asks, did you notice anything of interest in studies exploring psychosocial intervention only and psychosocial intervention alongside medical treatment for those seeking that?
Short answer is we don't know because for a couple of reasons. Firstly, the reason I just said that the studies are not targeted enough to people with gender dysphoria. And secondly, and this applies not only to the psychotherapy studies, the psychological studies, but with all of them, they didn't really give good descriptions of exactly what the therapies were. And because the populations are small, the sorts of comparisons that I think Teddy is interested in, which would be, does one-on-one counselling work with or without antidepressants, or if you've had hormone therapy, are you already at a lower level of dysphoria? Those sorts of questions haven't been addressed in the research that we looked at. These are very broad studies that essentially are looking at a global intervention with lots of different types of therapy and delivery modes and mixed populations.
And there are another couple of things coming through the chat. So thank you for such a fantastic presentation. Do you know if there are any of these studies are informing education and training materials for health practitioners? I'm thinking about ways to help mitigate problematic prejudices within healthcare to improve experiences when accessing care.
Yeah, thanks, Christine. And I think it's a really important issue. I think I'll just start with a general comment. A lot of people who are sort of at the coalface, so to speak, are really stretched in terms of being able to access and process information. This is particularly the case with therapists that might not see a condition as often as other conditions. So again, if I draw upon my spinal cord injury experience, pain in spinal cord injury is a very different phenomenon to pain in other areas. But if you're my local GP, you might see one person with spinal cord injury a year. You might not even see one in your career, or one every 10 years. So firstly, I think that there is a challenge with all relatively rare conditions, and gender dysphoria would fit into that category of, you can't get everyone across every condition. Having said that, and I'm not a clinician, but I would say that there is a pretty well-established network of gender dysphoria services and gender clinics. And I think they're probably going to be, I know, for example, that most of their websites, like the Children's Hospital, which I think is the biggest one in the country, do have access to materials. And they obviously, by the nature of the way the treatment pathways flow, they tend to take referrals. And that, again, is a bit similar to if a GP is seeing someone with spinal cord injury and they feel that it's not really within their scope of expertise, they would probably refer them to a specialist. So I think I don't know the answer to your question is I don't know the extent to which these studies are informing practice, but my mission in life as a reviewer is to kind of make it as easy as possible. So now people who do want to know about this can look at this report and, they'll save time by not having to look for the 82 studies. So we've done kind of the first step. And then, obviously there's a whole range of implementation issues about how researchers connect research to policy and practice. And that applies in gender dysphoria as well as in many, many other conditions.
There's a question from Vic. Did any of the psychosocial studies explore the impact of supportive families or peer support?
The short answer, Vicky, is I can't quite remember. I'm going to be completely honest here. I think that there would be, I'd encourage you to look at the report and just do a search for family therapies, because it's a big report. And if you do a word search, you should be able to find it. We didn't look at families or peer support as an independent, I guess, intervention, unless it was in the context of something like family therapy. So I think in terms of the question that you're asking, firstly, I can't remember. I'll just put my hand up, so I can't quite remember. But secondly, we wouldn't have looked at a study, for example, where they've interviewed adolescent, and I think we found some studies like this, but we excluded them. So if someone's done an exploration of the adolescent experience of gender dysphoria and compared and contrasted it based on peer support, that wouldn't have been within the scope of our review because it's an observational study rather than an evaluation. I know those studies exist, and I know that there will be a pretty large body of literature on the experience of having gender dysphoria and the influence of family and peer support. It just wasn't within the scope of the review. Vicky's got another question. Will I go to that one? The hierarchy of evidence. How might we collectively research the impact of the diversity of psychological and psychosocial approaches? Yeah, I think it's really hard, Vicky, because you've really hit the nail on the head with your comment, the significant degree of private services accessed. So the short answer is that the more distributed the service delivery is, particularly when you're in the realm of private practice, who don't traditionally, because they're not attached to a teaching hospital or university, they simply don't have the capacity to participate in that sort of research. The only sources you could go to, I think, that might be in terms of how we can solve this problem. So the professional colleges is one. So the professional colleges represent cohorts of practitioners that are distributed. They could certainly make efforts to mobilise research in that area, but the logistical and ethical complexities of trying to collect data from lots and lots of private practices is actually quite considerable. And so I imagine a study like that would be relatively costly. That doesn't mean we shouldn't do it, but the principle that I pointed out in the last slide about multi-centre studies also applies here. So when you've got small populations that are distributed, the only way you can make sense of a focused question, like the sorts of questions that are being asked here, is to gather up the numbers by collaborating. And as I said, you know, if you look at other conditions like motor neurone disease, spinal cord injury, and even brain injury, where they're sort of high impact but low numbers, that's the way that you can advance research, is to team up with a bunch of centres and enrol people in a consistent study protocol. Kenton Miller, how do you deal with those who might challenge the validity of your study when you've said there's not a large number of robust studies? It can be exasperating when the lack of evidence gets attacked. Yeah, Kenton, I think the thing is that if you look across all areas of medicine, there is it's a pretty dry and boring process, but essentially you collect the evidence and you report what it says. You know, I don't, you know, the validity of my study, I take to mean, have I done that in the most robust way for a review? Then what people make of the findings of the review is to an extent beyond my control. So I can certainly do talks like this where I say, this is what we did. We found the studies, we noted their quality. What happens in all areas of medicine is that then the medical and patient and stakeholder community and policy communities get together and they say, well, what are we going to do about treatment? And the thing about clinical practice guidelines is that they're very explicit about the strength of the evidence. So there are grading systems. If you look in any clinical practice guideline, you'll see that some recommendations are supported by a lot of studies, some are supported by less studies, and some are supported by really just expert opinions. So the processes for going from a body of research evidence to what do we do are pretty well established. Obviously, then there are people who have particular views about all treatments, and I know that, don't live under a rock, I know that gender dysphoria is a pretty hotly debated topic. My job as an evidence reviewer is just to say, this is the state of the science and report on exactly the methods that we use to come to that conclusion. And then in all of the reviews I do, the decision-making about what this means for policy and practice is the next step in the process. So that's how I that's how I deal with it personally. I'm a pretty senior researcher. I've had lots of questions about lots of the research I've done, and yeah, I just get on and here it is, and let's see what people make of it.
That's wonderful. Well, thank you very much, Peter. Thanks for sharing your insights and helping us better understand the current evidence base on gender-affirming care for young people. And thanks to everyone who participated in today's discussion. Like we said at the beginning, right now we're in a period where a discussion about healthcare for trans and gender diverse young people are being made at a political level, often without full consideration of the evidence or the experiences of those most affected. And this makes conversations like today's, where we focus on research, evidence, and what we actually know, really crucial. In the US, we've seen how quickly small erosions of rights snowball into devastating rollbacks, access to healthcare, legal recognition, even basic dignity. And so we can't afford to be complacent. We must demand fairness and access, because once our rights start slipping, the consequences are dire. So it is a very difficult time for many, particularly for trans and gender diverse people and their families who are feeling the impact of these debates in a very deeply personal way. Just a reminder that there is support available at QLife, and I'll give you the number for QLife. It's 1-800-184-527. Or you can visit qlife.org.au for information about services in your local area.
Ian, can I just add one thing? I know some people, and thank you for sharing the link to the Sachs Institute report. So everything I presented today is really a summary of that report. So if people are interested in accessing that information, the report, as I said, it's very long, but we've organised it in a way that you can engage with the front matter and get the key messages, just as I've done today. So I encourage people to access that report and read as much as they would like.
And so yeah, finally, I just encourage you to stay engaged with reliable evidence-based sources, such as the Transcend Australia website and AusPath, who will continue to update their resources as things evolve. We will be hosting another webinar very soon, so please look out for that. And I believe I will have your email addresses, so I will reach out to you and let you know when that's coming. Yeah, discussions like this matter because they shape real lives and real healthcare access. I'd like to thank Peter again and thank you all for joining. So thanks for being part of this important discussion. Please take care of yourselves and each other, and enjoy the rest of your afternoon. Thanks very much.
Thanks again, and thanks everyone for attending.
Bye.
Bye for now.